I'm Dr. P. Satishchandra. I am the moderator for this session. I thank the organizers for giving me this opportunity to moderate this session on neurosciences. Let me introduce myself. I am the advisor and senior consultant in the Apollo Specialty Hospital, Jayanagar, Bangalore, in India. And I was formerly the faculty member for more than 35 years at the prestigious National Institute of Mental Health and Neurosciences. I had the opportunity to head the institute as the director and the vice chancellor from 2010 to 2016. My area of interest being epilepsy, neuroinfections, including neuro-AIDS, and demyelinating disorders. Today, we are talking about neurosciences and the advances in this field. And especially, we have chosen three important areas. And for these three important areas, we have three speakers, two from USA, Professor Avindranath, Chief of the Infections of the Nervous System in NINDS, then Professor Sanjay Singh from Creighton University, and Dr. Vinit Suri from Delhi. We also have three chairpersons to chair each of these sessions. Now, I, at the outset, thank the organizers for giving me this opportunity, and also to tell this audience that we have a chat box, and any questions you have, you can ask in this chat box, and you will get the answers within a week from the speakers. I have a pleasure in introducing Dr. Prem Agarwal, who is the chairperson for the first session. Prem Agarwal is a renowned cardiologist in New Delhi. His area of expertise is in the area of emergency cardiology and critical care. Prem Agarwal is also founder of a well-known Sanjeevani Hospital in the central Delhi and also founder of Medical Dialogues. Now I have pleasure in inviting Dr. Prem Agarwal to invite our first speaker, Professor Avindranath, to deliver his talk. Over to Dr. Prem Agarwal.
Hello, everybody. First of all, I would like to thank Dr. Satishchandra for introducing me. And also, I'd like to thank GPO for inviting me to chair this session. It's a pleasure to introduce the first speaker of this session, that is Mr. Avindranath, who is a physician-scientist specializing in the field of neuroimmunology and neurovirology. Mr. Nath is an internationally recognized person for his contribution and has served on the number of advisory committees, like that of the National Institute of Health, Center of Disease Control, FDA, and World Health Organization. Dr. Nath is also a recipient of prestigious award, that is Vibrant, and Vibrant from the Society of Neuroimmune Pharmacology and contribution to the neurovirology, and also the recipient of the HHS Secretary Award for his work on Ebola infection. Mr. Nath is a clinical director of National Institute of Neurological Disorders and Stroke, where he is also chief of section of disease and director of Translational Center of Neurological Sciences and director of Neuroimmunology and Neurovirology Fellowship Program. Such a distinguished speaker, I invite Dr. Avindranath to kindly deliver a lecture. Thank you very much. Dr. Avindranath.
So I'm going to talk about the neurological complications of COVID-19. And I am currently the clinical director at the National Institute of Neurological Disorders and Stroke in Bethesda, Maryland. And my area of expertise is neurological infections. So the complications can be divided mainly into two types of presentations. One is the acute presentations that occur during the phase of the acute syndrome. And here, patients can present with a variety of different neurological manifestations that can include loss of smell and encephalopathy, stroke-like presentations, meningitis, seizures, leukoencephalopathy, and an interesting brainstem syndrome that is called Ondine's curse. There are a variety of post-viral syndromes that can also occur, and these are all immune-mediated, and they can affect the brain, causing a variety of different types of encephalitis, or they can be more multisystemic and involve multiple organs at the same time. So if you look at it, just encephalopathy in patients with COVID, in hospitalized patients, about a third of patients had some kind of altered mental status. And those with altered mental status are in the hospital almost 3 times as long. And at the time of discharge, 2/3 of them are unable to manage their daily activities. And this seems to be more common in older individuals and is independent of the respiratory illness itself. There are different types of encephalitis that can present, and let me show you some examples of those. So very rarely do you see a viral encephalitis. This is at least one case report whereby virus was detected in the spinal fluid and the patient presented with signs of meningitis as well as a generalized seizure, and the MRI showed some abnormalities on the temporal lobe. However, this is an exception rather than the rule. There are a number of patients who can develop an acute disseminated encephalomyelitis. So you can see these ring-like lesions in the brain and lesions in the spinal cord here, suggestive of inflammation at both sites. And this patient also had inflammation along the optic nerves. And then, there is another rare type of encephalitis that can occur in these patients, and that is an acute necrotizing hemorrhagic encephalopathy. You have these bilateral lesions in the thalamus, and it's associated with some bleeding in that area. And there can be lesions elsewhere in the brain also, but they're always bilaterally symmetrical. This is a neuropathology paper published from Germany where they show that there's huge amounts of inflammation in the brain at the time of autopsy. So you can find macrophages in collections around blood vessels. You can also find CD8 cells, and both macrophages and microglial cell activation can be seen in the brain. You can also find it in the meninges and also in the perivascular spaces, suggesting there's some breakdown of the microvasculature in these patients. However, there's very little virus that can be detected. So these cells it's not still understood what these cells are really after, because the target antigen still remains unclear. Strokes are common in these patients and can present in a variety of different ways. The interesting thing is that these patients can develop arterial occlusions, and multiple arteries can be occluded at the same time, or you can get a combination of arterial and venous occlusions. So patients can get cerebral venous thromboses, and they can even present with pseudotumor cerebri from these venous occlusions. And they can present with DVTs, pulmonary embolism, renal artery stenosis, as well as brain infarct, all at the same time. Some patients can develop microhemorrhages, and the pathophysiology is also quite complex. It's very clear a number of patients do develop antibodies to phospholipids, and some patients can develop myocarditis, and then underlying vascular risk factors does make them at greater risk for developing strokes. Here's an example of a patient who has occlusions on both sides of the brain, multiple arteries being involved in the middle cerebral artery territory. And here's an example of a patient with microhemorrhages. So you can see lots of microhemorrhages throughout the brain. And then other parts of the nervous system can get involved. So here's an individual with polyradiculoneuritis, and you can see inflammation of the roots coming out of the spinal cord. And this is the L5 nerve root here. And you can see that is also enhancing here. And this patient had paresthesias, allodynia, and there was acute denervation on the EMG. The interesting thing is they respond to immune modulatory therapy, so IVIG was sufficient to control it. Then there are some patients who develop Guillain-Barré syndrome, but what is even more interesting is that there are a variety of variants of Guillain-Barré that have been reported in the literature. A number of patients with Miller-Fisher syndrome or multiple cranial nerve involvement. Here's an individual with ophthalmoparesis, as you can see, and also enhancement, as you can see here, of the nerves in the oculomotor nerve over here in this individual. Again, swelling here in the orbital socket. And then the muscles can get involved, both cardiac and skeletal muscles. And you can see here there's enhancement of the muscles in the spine. There's necrosis here in the muscles here, in the thigh here. And on, excuse me. And if you look at the pathology of the muscle here, you can see there's inflammation scattered between the muscle fibers here. And you can see regenerating muscle fibers as well as expression of HLA antigens. But the biggest problem we will face is this entity that's called long COVID or long haul COVID. Now, these are patients who have recovered from the acute phase, but continue to complain of a variety of neurological manifestations that includes exercise intolerance and headache, insomnia, chest pain, and cough, even though all CT scans of the chest are normal in these individuals. They have a skin rash, joint pains, and also they complain of persistent fever, but it's usually 99 something, so it's thought that it's really due to autonomic disturbances and vasodilatation, and not due to some persistent infection. It has a overlap with what we call chronic fatigue syndrome. And so many of the symptoms look similar to that. The cardiac arrhythmia is another problem. These patients complain of palpitations every time they stand up, and it can, and the dysautonomia can be very profound in some individuals. I know of one neurologist who cannot even get out of bed, she says, because every time she does, she gets hypotensive and gets profound tachycardia. It's for some reason it's more in women compared to men, and so this is a problem that we're going to be facing with for a long time to come, despite the availability of vaccines. It's been also called the post-acute COVID, and just as I mentioned, about 40% of individuals at 12 weeks continue to complain of these symptoms. They also complain of cognitive difficulties. Most of these patients say they have brain fog, but really what they mean is they have short-term memory loss as well as concentration problems. And some have distortion of time. Events that may have occurred, say 1 day ago, it appears to them they may have occurred a month or a week ago. So they have difficulty with time management. And headache, pain, insomnia, as I said, was quite common. So neurology should be involved very early in the care, especially for all ICU patients, I think. Otherwise, things get missed. Acute stroke, if tenecteplase is available, it's preferable to TPA because you can give it within 5 seconds, which is a lot faster, and exposure and risk of patient to physician infection is also lower that way. IVIG can be used for various immune syndromes, and this is certainly preferable to using corticosteroids. And those patients who have underlying neurological disease are more prone to respiratory infections, of course, and patients with dementia may not report symptoms of infection. So so these patients really need special care when they develop the infection. So I'll stop here.
I thank Professor Avindranath for delivering a very interesting lecture on COVID and neurology. He has given the illustrated accounts about the acute manifestations in neurological disorders as well as the post-COVID neurology. I thank also the Prem Agarwal for introducing Dr. Abhinath and chairing this session. Let us move on to the second session. The second part of our program today is a second talk which is chaired by Dr. Vinay Agarwal. Dr. Vinay Agarwal is a well-known family physician and also specialist in heart diseases. He is held a number of important administrative positions in the past as a past national president of IMA, past president of Confederation of Medical Association in Asia and Oceanian region. He was also former member of the Medical Council of India and an executive member of the Delhi Medical Council. I have pleasure to invite Dr. Vinay Agarwal and request him to introduce the second speaker, Dr. Vinit Suri, well-known neurologist from Delhi, to speak on the stroke and recent advances. So over to Dr. Vinay Agarwal.
My thanks to Dr. Satishchandra, the moderator of the session, for his kind introduction. I'm also thankful to Gapio for giving me this opportunity to chair the session on neurosciences during the Global Indian Physicians Congress. Friends, I have been given an onerous duty to introduce a very dear friend of mine and a key speaker during this session, Dr. Vinit Suri. Dr. Vinit is a senior consultant neurologist at Apollo Hospitals, Delhi. Suri is a member of Indian Stroke Association, Neurology Society of India, Indian Academy of Neurology, American Society of Neurology, and executive member of Delhi Neurological Society. Dr. Suri has published numerous research papers. Suri is on Neurology Editorial Board of International Journal of Contemporary Pediatrics and an associate editor of Journal of Indian Stroke Medicine. Dr. Suri is also the past president of Indian Stroke Association. Dr. Suri is a name in North India in the field of neurology. I'll now request Dr. Suri to start his talk and the session. Thank you.
At the outset, I'd like to thank the Global Association of Physicians of Indian Origin to give me this opportunity to be here with you today. And I would like to thank the moderator for the session, Dr. Satishchandra, and Dr. Vinay Agarwal for this kind introduction. I'm going to talk today on stroke, on current management of ischemic stroke and what is new. So in just about 8 minutes, it's a very tall task in 8 minutes to tell you what all is new, but I'll run through a very, very practical type of talk and give you details of what is new in management of acute ischemic stroke. So basically, we'll talk only about recanalization. Recanalization is where we open up the vessel. And for IV thrombolysis, this window is for about 4.5 hours. For mechanical thrombectomy, it's about 6 hours. Then following recanalization, the second step of management usually is the stroke ICU management, which is beyond patients who come beyond the window. And simultaneously also one tends to do rehabilitation and prevention of the net stroke, but we are going to focus today only on recanalization management. Acute stroke management involves pre-hospital care, which is when patients are seen in the OPD or in the outside OPD setting. Then the triage management, when the patient reaches a hospital setup, then what is the triage management, then the recanalization, and then the stroke ICU care. Pre-hospital care, it is important for patients to remember that anybody who has symptoms of the mnemonic B fast, B standing for abrupt onset of balance problem, E stands sudden onset of visual problem in one eye or both fields of eye, or face is turning to one side, or there's an arm drift, or there is a speech slur or a difficulty in speaking. So if there are B fast signs, then it is usually a stroke, and these patients should rush to a hospital. One should remember that when you see these patients in the outpatient, even if they have a mild facial weakness or a right arm mild drift, stroke is a medical emergency, and all these patients should be hospitalized urgently. Even if it appears to be a minor stroke, there is nothing like minor stroke because 25 to 40% of these patients may deteriorate over the first 24 to 48 hours. So as soon as you identify symptoms of BFAST, hospitalize these patients. What you can do at that moment in the outpatient clinic is check for hypoglycemia. If the sugars are less than 60, then it's a stroke mimic. It's actually not a stroke. And you give dextrose solution and these patients may recover. Do not lower the blood pressure unless and until the blood pressure is more than systolic 220, diastolic more than 120. Try not to give aspirin if the patient is especially in the window period, because then the patient may be thrombolized or be taken up for mechanical thrombectomy. Once the patient reaches the triage, usually the first step is stabilization, where an IV access on the non-paralyzed arm is done, and normal saline, avoid dextrose solutions. Normal saline is usually started in euvolemic patients at about 50 ml per hour. Continuous cardiac monitoring is done. Oxygen saturation monitoring is done. And stroke mimics should be ruled out. So stroke mimics are ruled out by a CT scan or an MRI. Rule out tumors, brain abscesses, tumors. An NIHS score is done, which is a score on 11 points. And the maximum score can be 45. The lowest score is 0. Patients who have a less than 10 score will usually do extremely well with IV thrombolysis. Usually a CT scan is sufficient enough to go ahead and thrombolyze these patients. And if the CT scan excludes out a bleed, you can take up these patients for thrombolysis. Usually one should try to look at on CT scan for some hyperdense vessel sign, which is a very early sign to suggest that there may be a blockage in this vessel. Hyperattenuation of gray matter or effaced sulci is what you will see initially. We usually do what is called as an aspect score. So the MCA is divided into 10 parts. Each part is scored 1. Whichever part is hypodense is subtracted from 10. So if you have 2 parts which are hypodense, the score aspect score is 10 minus 2, that is 8. Any patient who has a score of aspect more than 6 usually will do extremely well, and they can be taken up for mechanical thrombectomy or for IV thrombolysis. Then advanced imaging involves CT angio and MR angiography. CT angiography will tell us whether there is a large vessel occlusion. Usually a multi-phase CT angio is done, and that gives us good information about which vessel is blocked, and it also gives us good information about the collaterals. So patients who have a large vessel occlusion, who have good collaterals, are good candidates for IV thrombolysis or for mechanical thrombectomy. CT perfusion is the other test which is done, which actually identifies what size is the core and what size is the ischemic penumbra. And patients who have small core and a large penumbra are candidates for recanalization therapy. MRI becomes positive in about 3 to 10 minutes. And MRI is extremely helpful because it can actually time the stroke also. Diffusion images remain positive from 10 minutes to almost about 21 days. And ADC drop-in signal usually lasts for about 10 to 15 days. So an MRI can also identify especially small lacunar infarcts in the brainstem. It can identify if there is a hemorrhagic component. It can actually tell you if there are multiple microbleeds or any other contraindication for thrombolysis. All the tests that you need for thrombolysis is a CT scan and a platelet count. If you have a platelet count, you need not wait for platelet count, PT, PTT. If you think that the patient does not have any hematological disorder, one can just do sugar levels, CT scan, and go ahead and thrombolyze these patients. Recanalization therapy can be done by using alteplase or tenecteplase. And one should remember that as more and more time passes, the chances that the patients are going to do well drops down. So if you thrombolyze a patient within the first 90 minutes, number needed to treat for a good result is 4, but it drops at 4.5 hours to about 21. So earlier you treat these patients, the better the outcome. Then there are inclusion and exclusion criteria. All patients who are between 18 to 80 years of age can be thrombolyzed. Ischemic stroke with a measurable deficit and onset of symptoms less than 4.5 hours. There are a lot of contraindications. I'm not going to detail, but what I would like to mention is in the 2019 guidelines, a lot of these exclusion criteria have been removed, and they have been now modified to what is called as additional recommendations, which means you can actually thrombolyze these patients with weighing the risk and benefit ratio, and the neurologist can actually take up a lot of these initially so-called contraindications are now additional recommendations, and you can select these patients. What is the prerequisite is that the blood pressure should be kept at the time of entry into thrombolysis. Blood pressure should be less than 185, 110. Which arm should one check the blood pressure? Check both arms. Whichever is the higher blood pressure, that arm is used. And post thrombolysis or during thrombolysis also, the blood pressure should be kept less than 180, 105, at least for 24 hours during and post thrombolysis. Like I said, PT, PTT, and platelet count are required, but if the patient does not have a suspected hematological abnormality, one need not wait for these reports, and one can thrombolyze just on the basis of a blood sugar and a CT scan. A consent is required, even though it's a licensed form of therapy, And when you're thrombolizing patients beyond guidelines, then take a consent for beyond guideline. The dose for alteplase is 0.9 milligram per kilogram body weight, 10% given as a bolus, and the rest is given as over 1 hour as infusion. Tenecteplase in a 0.25 milligram per kilogram body weight is used as a single bolus. Maximum dose that you can use is 25 milligrams. And post thrombolysis, one should keep the blood pressure to less than 180, 105. Do not give any antiplatelets. Do not use any low molecular weight heparin for 24 hours. Keep a watch for any orolingual angioedema, and the most feared complication of intracranial hemorrhage, 6 to 9%. It may occur in 6 to 9% of patients, and it may be fatal in 50%. So this is the most feared complication. And the AHA guidelines have actually now put the guidelines that you can actually thrombolize patients even above the age of 80 years. You can thrombolize patients who are diabetic with a prior stroke, and you can also thrombolize patients who have an NIHS score above 25, and patients who have a non-STEMI infarct, coronary artery infarct. You can thrombolize these patients. Patients who are undergoing dialysis, patients who are pregnant, patients who have had a diabetic proliferative retinopathy, you can thrombolize these patients also. And the new thing that has come up is that wake-up stroke patients, if there is involvement of less than 1/3 of the territory of MCA and they are flare negative, you can thrombolize these patients as well. And the EXTEND trial has shown some light that you can actually go beyond 4.5 hours, but this is something that needs more trials. So the window still remains 4.5 hours unless until you have a wake-up stroke. The other thing that can be done is mechanical thrombectomy, and there are about 7 trials which have shown the efficacy. So any acute ischemic patient who has an NIHS score of above 6, aspect score on CT scan above 6, and a CT and MR angio showing a large vessel occlusion in IC or M1, M2 is liable to, you can take these patients for mechanical thrombectomy. And these patients can be taken up if their symptom onset is within 6 hours. But there is now criteria based on dawn and diffuse. If the patient has a small core of about 51 ml in the dawn criteria and diffuse about up to 70 ml, then you can take up these patients even up to 24 hours. So most patients of mechanical thrombectomy will be those who have symptoms onset within 6 hours. But if patients fit into the dawn and diffuse criteria, small core, large ischemic penumbra, based on CT, MR, or perfusion studies, you can actually thrombolize these patients up to 24 hours. Then the stroke ICU management, these patients who are beyond reperfusion or who have been reperfused are then shifted to a stroke ICU, where aspirin is given after 24 hours of a thrombolytic agent. There is no role for any neuroprotective agent. And low molecular weight heparin is used only for in a DVT preventive dosage, and you do a swallowing test before you take patients up for feeding. And early mobilization is recommended. Decompressive cranectomy is required for patients who have a malignant MCA infarct, that is, patients who have more than 50 to 75% of the MCA territory infarcted, or who have a more than 4 millimeter midline shift in the first 24 to 48 hours. They are taken up for a decompressive cranectomy where a bone flap is removed. And these patients, you can actually, the number needed to treat is 50%, which means if for 50% patients will survive if a decompressive cranectomy is done well in time. So I think just the last slide here to just give a glimpse of how stroke is managed. As soon as you identify a patient with BFAST, admit these patients, investigate them with either a CT scan or a multimodal MRI and a CT angio. IV thrombolysis is done up to patients who are within 4.5 hours. Wake-up stroke can be taken up beyond 4.5 hours if they are flare negative and the stroke is involving less than 1/3 of the MCA territory. Mechanical thrombectomy can be done up to 6 hours, but in selected patients up to 16 to 24 hours. And patients who present beyond that, then only stroke ICU care, where you give general care and aspirin and heparin in DVT preventive doses. Thank you so much for a patient hearing.
Excellent exposition of recent aspects of management of stroke. The technology has revolutionized the treatment in the field of stroke, both for diagnosis as well as for the management. And Dr. Vinit Suri has brought this out very clearly. I thank Vinit Suri for this excellent lecture, and also thank the chairperson, Dr. Vinay Agarwal, for introducing the speaker and conducting the second talk. Thank you. Let us move on to the third talk of the day. The third talk is on epilepsy, a new era. And this will be delivered by my friend, Professor Sanjay Singh, head of the Department of Neurology in the Creighton University, USA. This epilepsy in the new era will be spoken by Sanjay Singh, and he will be introduced by Chairperson Dr. B.B. Wadhwa. Dr. B.B. Wadhwa is a well-known family physician, primary care physician in Delhi, and he has a selfless service to the underprivileged children in Delhi, and he is working on for this field for more than 35 years. He is the president of the Delhi Medical Association. Dr. B.B. Wadhwa is the project director of IMA Literacy Mission, and through this banner, he has worked for the underprivileged children and successfully educated more than 200 children in Delhi since 2006. Now I invite Dr. B.B. Wadhwa to kindly come forward and invite the third speaker of the session, who is internationally well-known epileptologist, Professor Sanjay Singh. I now invite Dr. Wadhwa and take up his session and go on further with the third talk. Over to Dr. B.B. Wadhwa.
Namaskar, I am Dr. B.B. Wadhwa, President Delhi Medical Association. I am here today to introduce a towering personality of Indian origin, Dr. and Professor Dr. Sanjay Singh. Professor Sanjay Singh is Chairman and Professor of Department of Neurology at Creighton University School of Medicine, and he is the Director of Neurological Institute of Creighton Health, Creighton University School of Medicine, and is also Medical Director of Neurosciences Services Line. Professor Sanjay is Chief of Staff of Creighton Health Institute, Health Center, and also has been Chief Academic Officer at CHI Health. Professor Sanjay is a member of CFAS, Council of American Association of Medical Colleges. Professor Sanjay is on the UCNS Accreditation Committee and the Award Committee of American Board of Psychiatrists and Neurologists. Professor Sanjay is currently the Professor of Association of Indian Neurologists of America. Professor Sanjay is the author of many acclaimed titles like Locktail, and he is written Handbook of Neurology. He is the author of numerous articles and has published many books in his line neurology. Professor Sanjay has been the recipient of numerous awards, and he has been honored by the A.B. Baker Teachers Recognition Award, by the American Academy of Neurology, UNMC Chancellor's Gold U Award, and many other awards to his name. Professor Sanjay has been a name to be recognized with neurology of America as well as India. Professor Sanjay was awarded the Lifetime Achievement Award at Indo Global Healthcare Summit in Hyderabad, and he has been awarded Hind Ratna Award by the Prime Minister at New Delhi. Thank you.
Hi, it gives me great pleasure to give this talk on epilepsy in New Era. I want to thank Dr. Satishchandra, and I want to thank the organizers of Global Indian Physicians Congress and the Apollo Group for giving me this opportunity to share this information with you. I am now going to start my presentation. So the topic that was given to me was epilepsy in New Era, and I'm going to utilize this presentation to go over some of the important newer concepts in epilepsy care. So I'm not going to spend a lot of time on what we already know, but for the audience, every epilepsy or seizure patient must get two basic tests. One is an MRI of your brain, and one is an EEG. And about 70% of patients do fine with just these two investigations. But about 30 to 35% of patients, they do not respond to routine medical therapy, and then they require a 4-phased workup that I've shown over here. And the idea is to find where seizures are coming from in the brain so that we can then plan for further surgical and neuromodulation treatments. The newer things here are the magnetoencephalography, which you're seeing here. And this is a large device that's actually recording the magnetic activity of your brain. And that really tells us where the abnormality in seizures may be. It can also help us map out your brain. So we can find out where your motor area is, where your sensory area is, where your vision areas are. So that's a very important thing to kind of keep in mind. In terms of treatment, the mainstay of epilepsy treatment is anti-epileptic medications. And as you can see, since 1990 onwards, we've almost had a medication every year. And this is just not happened by itself, but a lot of planning and strategy has gone into this, and drug development modules have been created by the NINDS and other bodies that have led to this discovery. And more recently, we've had another addition to these anti-epileptic drugs. But still, about 35% of patients do not respond to anti-epileptic medications. And therefore, then we have to consider other means. So we do epilepsy surgery, which is where we find out where in the brain the seizures are coming from. We make sure that's a safe area of the brain to cut, and we cut that region out. And then if surgery fails or someone is not a candidate for surgery, then neuromodulation techniques are utilized, like the vagal nerve stimulator, which is here, the deep brain stimulator, which we utilize here, or the RNS, which is a much more invasive technique, which can also be utilized in these methods. Now let's move on to what's really new in epilepsy care. So I'm going to talk about how personalized medicine really is important and how is it practiced and what is the future in epilepsy. We'll talk about the cerebral organoids in epilepsy, artificial intelligence, incisionless brain surgery or exablate, and then augmented reality, and how all of these are really the current and the future of epilepsy care. So what do we mean by personalized medicine? Personalized medicine means that you don't just throw a drug at a population of patients, say, of epilepsy. You actually fine-tune the treatment to what is required for that individual patient. Now, how do we do that? So we have the ability to now do this whole genome sequencing for just a few $100s now. And so the whole genome sequencing helps us quite a bit in this endeavor. The second is that epilepsy, like with a lot of other disorders, has a number of genetic abnormalities that could cause that epilepsy. And the third component is CRISPR, which, as you know, is a revolutionary gene editing technology. So we can edit any gene in a way we have never been able to do in human history. So how do these three things come together? In an epilepsy patient, we can do whole genome sequencing and figure out what is the genetic abnormality. We take that genetic abnormality and produce it in an animal model like a mouse. And then in that animal model of epilepsy that is unique to that patient, we try a series of medications, and then we find which one works and give that information for that individual patient to his treating physician. So that is what personalized medicine really is in epilepsy. The second is growing a brain in a dish. And this has really become a reality in today's time, something that was science fiction just a few years ago. So these are cerebral organoids. So essentially what happens is that you grow brains in a dish with stem cells. So how do you do that? So you take skin cells and you change them into pluripotent stem cells. And then through those pluripotent stem cells, you create neuroectodermal progenitors, and then that can be further refined into neural tissue. So down here, I've shown you the reprogramming of skin cells into human-induced pluripotent stem cells, and then finally growing them into a three-dimensional brain. So how is that useful? So you can grow a whole brain organoid. You can grow regional brain organoids. That means like a cortex, like a medial eminence, or even a hippocampus. And then you can even fuse organoids and see. So there is this organoid generation, or brain generation. And then there is the analysis. So you can do electrical analysis, networking analysis, all of which is very critical in epilepsy. And then you can use this cerebral organoid or this brain in a dish and test drugs and screen drugs in these models. So in epilepsy, there are a number of developmental epilepsies in which work has just started by using these cerebral organoids. And that is really exciting because if you're testing it in animal models, the real difference between animals and us are our brains. Right? And therefore, animal models have not been found to be perfect or really near perfect for neurological disorders. And therefore, this development is of real importance. But it also throws up all kinds of questions because the cerebral organoids have now shown that they can generate spontaneous electrical activity of brain waves. Right? So then the question is this brain in a dish conscious? Is it alive? Because now we can keep cerebral organoids and keep them growing for 1 to 2 years. And it has been seen that at 9 months, when a baby is born, there's a significant change in these cerebral organoids. So they're mimicking a real brain. So clearly interesting and in some ways ethical questions are about to be asked about these growing a brain in a dish. The third thing I wanted to talk about was artificial intelligence. The first artificial intelligence medical application was approved in stroke care in neurology. Essentially what that is that you have an AI or an artificial intelligence algorithm which is monitoring CT scans and picks up any large vessel strokes, right? And tells the on-call neurologist that there is a large vessel stroke. Not only tells or pages the on-call neurologist, but also sends the picture on your smart devices. So you can actually see CT scans, CT angiograms, perfusions. And so what the process that used to take a few hours now takes 6 minutes. So clearly a lot of brain cells are saved. Our group has been working on artificial intelligence in EEG and epilepsy. And so we've developed an algorithm, which we've recently presented at a national meeting here in the United States, of an algorithm picking up or being able to recognize seizures. And that is really important because otherwise you'd require a neurologist with training in EEG to do this. And so this is an important step forward. And now we are working on other parts to actually look at some of the more detailed analysis of EEGs too. So AI is going to play a big role. This is incisionless brain surgery. So this is where you use focused ultrasound and you burn parts of the brain out. So at our center, we use this in essential tremors and Parkinson's tremors, where we burn a part of the thalamus. And the exciting part is that the patient comes in walking, gets this procedure, and goes home within 2 to 3 hours, right? This is incisionless outpatient brain surgery. And now the equipment has been modified so you can actually not only burn small regions like within the thalamus, but you may also be able to burn a region like the hippocampus. And so it'll have use in epilepsy and also in brain tumors and other fields. But this incisionless brain surgery is really important. And there are trials now that have started in epilepsy. And then finally, augmented reality or X vision. So what is this? So the surgeon wears this helmet and to this helmet, we have MRI and CTs are fed into this. So you have three-dimensional spinal anatomic and two-dimensional CT images projected directly onto the surgeon's retina. Remember, the surgeon's retina. So as the surgeon is viewing this, he almost has X-ray vision. So as he's operating on the spine without a large incision, he's actually able to see the spine and where his instrument is on the spine because of this augmented reality. This has been just approved in the United States for spine surgery, but it will have major impact on other neurosurgical procedures, including epilepsy surgery. So in reality, the world of epilepsy is changing right before our eyes, and advanced technology is having a major impact on this. And I hope I've been able to convey the excitement that is there in this field and the revolution that is taking place right in front of our eyes as this field develops and we can treat our patients in a much better manner. Thank you.
I sincerely thank Professor Sanjay Singh, who gave a very important talk on epilepsy, a new era. And I also thank Dr. B.B. Wadhwa for introducing our third speaker and chairing the session. Today, we have in this neurosciences session three important talks. Professor Ravindranath spoke about the COVID and neurology. As we are all going through this pandemic, we thought that COVID is only a respiratory disorder. But now we understand that it affects many systems, and especially the nervous system. Dr. Ravindranath has brought out very clearly the neurological manifestation associated with COVID and also the post-COVID era, and how to make the diagnosis and also the management. In the second talk, Dr. Vineet Suri spoke about stroke. The stroke is the commonest neuroemergency, and we have a lot of advances in the recent era. Dr. Vineet Suri has justified that time is brain, and we need to act immediately when a patient with stroke lands in the emergency. And we need to take it further with both medical line of treatment as well as surgical intervention. The neuro intervention in the form of mechanical thrombectomy has completely revolutionized the management of stroke in reducing both mortality and the morbidity. In the third talk, we had Professor Sanjay Singh talking about epilepsy, which is an age-old disorder. However, with the technology, we had a lot of advances both in the diagnosis and the management. And in the years to come, the whole concept in the management is going to change. And that is what Professor Sanjay Singh has brought about, how the artificial intelligence, how the surgery, as well as the brain in the dish has changing the concept of management of epilepsy. I thank all the speakers and the chairpersons for giving their valuable time in participating today's session on neurosciences in the Conference on Global Campaign, Global Association of Physicians of Indian Origin. And also, I remind all the delegates to ask there any questions in the chat box, and your answers will be with you within a week's time from our speakers. Thank you one and all.